Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice case of unusual presentation of a small cell lung carcinoma, which is presented with bone pain and on initial presentation, bone marrow metastasis. So this is a case of a 52-year-old male patient who started to complain of generalized bone pain of several months duration. So he underwent CBC examination and was found to be cytopenic, for which he underwent bone marrow and blood film examination on the assumption that the patient has multiple myeloma. On examination of the blood film, as you can see, there is a clear evidence of pancytopenia. So barely seen platelets, so consistent with the thrombocytopenia, barely seen mature myeloid elements. On the contrary, what we see is the immature myeloid elements as well as nucleated red blood cell. On another field, barely seen platelets, so thrombocytopenia, nucleated red blood cell, and then promyelocyte, another one, band cell. So there was a clear evidence there is a high power magnification, the promyelocyte with the eccentric nucleus, the granular cytoplasm, as well as the nucleated blood cell. A clear evidence of what we call leukoerythroblastic reaction, which means that the bone marrow is infiltrated by a process. And this is actually the bone marrow in which it was almost totally replaced by a small round blue cell tumor that on high power magnification, as you can see, total replacement of the bone marrow by this kind of highly malignant small round blue cell tumor that focally showed tendency at rosette formation. On higher power magnification, very high NC ratio, abnormal forms with oat-like appearance of the tumor cells, some apoptotic cells here and there. And this is high power magnification of the area where we have some tendency at rosette formation. And the differential diagnosis is wide, but definitely this is not multiple myeloma, and we have to consider metastatic carcinoma. So pancytokeratin showed this focal, not very impressive positivity, but definitely it was positive, showing this dot-like cytoplasmic positivity, which points towards a neuroendocrine type of carcinoma. Synaptophysin, strong diffuse positivity in the cytoplasm of the tumor cells everywhere in the bone marrow, as was CD56, which was a strongly diffusely positive, and then TTF1, a strong diffuse positivity of TTF1 in the tumor cells, and the Ki67 was extremely high. Now, on further investigation, the patient was actually found to have left hilar mass as well as innumerable liver lesions, for which he underwent liver biopsy. And as you can see in the liver biopsy, there are aggregates here, for example, of what looked like exactly the same tumor that was present in the bone marrow. Another focus here is also identified, another focus here, and this would be in a way correlated with the innumerable lesions or metastatic lesions that were present in the bone marrow. And this is TTF1 showing those small foci of positivity of metastatic small cell carcinoma, as was the synaptophysin, some larger groups of tumor cells, some individual tumor cells showing the positivity, and the CD56 again highlighting the positive, small and larger, but definitely not that large metastatic foci, and the Ki67 was also positive. What was really positive also in the background, and perhaps if you're not alerted to this, you would miss it, is the presence of those scattered larger cells in the sinusoids, which labeled with CD61, consistent with megakaryocytes, as well as those groups of small rounded cells which were positive with MPO, consistent with immature myeloid elements in the sinusoids of the liver. So the liver had actually two types of pathologies, the metastatic small cell carcinoma as well as extramedullary hematopoiesis, to compensate for the bone marrow failure that is really reflected on the cytopenia and the leukoerythroblastic reaction seen in the bone marrow. So the final diagnosis in this case was the bone marrow showing leukoerythroblastic reaction. The bone marrow trephine showed infiltration by small cell lung carcinoma, proven by morphology, immunostain, and correlation with the radiological findings. And then the liver showed metastatic small cell lung carcinoma presenting itself as small nodules that were seen as innumerable liver lesions on imaging, and definitely it correlated with the findings in the liver, as well as evidence of extramedullary hematopoiesis with the presence of megakaryocytes as well as immature myeloid elements in the bone marrow. I think this is a fascinating case, the way it presented the initial complaint of the patient, the progress of the investigation, and then the final findings of a hilar mass that really correlated with the metastatic small cell carcinoma into the bone marrow and the liver. I hope you find this tip useful in your daily practice. Thank you.